beta-hydroxybutyrate has a direct effect on the assembly of a genetic regulatory entity called the NLRP3 inflammasome. And this is like a regulating gene expression control that alters multiple downstream genes in the inflammatory cascade. And so this explains the dramatic anti-inflammatory effects that we see once people are effectively keto-adapted.
Beta-hydroxybutyrate, BHB, a ketone produced by the liver from fatty acids. It blocks the NLRP3 inflammasome-mediated inflammatory disease. When keto-adapted, or fat-adapted, we severely reduce chronic inflammation.
In addition, because the beta-hydroxybutyrate alters the epigenetic effect on histone deacetylases and reduces reactive oxygen species, when you have beta-hydroxybutyrate present, it reduces the impact of reactive oxygen species on membrane polyunsaturated fatty acids, which get turned into pro-inflammatory agents called isoprostanes.
Histone deacetylase, an enzyme that removes the acetyl group from histone proteins on DNA, allowing the histones to wrap the DNA more tightly. BHB alters the epigenetic effect on histone deacetylases and reduces reactive oxygen species, ROS, thus reducing their effect on membrane polyunsaturated fatty acids before they turn into pro-inflammatory isoprostanes.
Our reactive oxygen species just attack a membrane. There's no enzyme involved. And when it attacks the membranes and damages the polyunsaturated lipid, it produces pro-inflammatory compounds.
In summary, BHB presence in cells reduces inflammation.
It gives us a very credible mechanism for why we see dramatic effects on type 2 diabetes when we counsel patients and get them to follow a well-formulated ketogenic diet.
It helps us understand why people on a well-formulated ketogenic diet have dramatic positive effects on type 2 diabetes.
This concept of inflammation as having a role in diabetes is a new concept, but we're making progress. The first paper that I can identify that was in a mainstream journal that said, look, this is important, was the first of these papers by Bedonath and Schnolsen that was published in 2011. This is a Swiss group, and this was looked upon with great askance. But those guys are pioneers. Jerry Olewski's group, these are leaders, these are thought leaders in diabetology. And when they publish a paper in Journal of Clinical Investigation, it says inflammatory mechanisms linking obesity and metabolic disease, when the mainstream says, this could be important, and they put it in a top-ranked medical journal, then you know we're making progress. Probably one of the most important papers I was involved with was a study that was done primarily by Jeff Volek's group, and published this back in 2008. This was a randomized controlled trial of people with metabolic syndrome, not really severe metabolic syndrome. One dietary intervention was a well-formulated ketogenic diet. Right-hand side, LCD, 20+% protein, and about 12% carbs. So the other arm got randomized to a balanced diet, a low-fat diet, where they were told to only eat 1,500 calories per day. One was a restricted diet, one was eaten to satiety. On the low-fat diet, they only ate 12 grams of saturated fat per day. On the high-fat diet, they were eating 36 grams of saturated fat per day. They were eating a lot more fat than that. This wasn't high saturated fat in proportion, but they were eating 3 times as much saturated fat on the low-carbohydrate diet arm. As we usually see, when you do a well-formulated ketogenic diet right, people on the ketogenic diet lost twice as much weight as the people on the low-fat, high-carb diet. On this complex graph, if you look at those factors which are outlined in green, those 4 factors outlined in green are the parameters that define metabolic syndrome. Abdominal fat content by DEXA was significantly, the loss was significantly greater with the ketogenic diet in red. Triglyceride reductions were dramatically better. Both the other groups were restricting calories, losing weight, so they were getting better. That diet is working to improve their metabolic health, but the ketogenic diet worked better. In terms of HDL cholesterol, there was about a 15% rise in HDL cholesterol with the ketogenic diet. There was no change with the other diet. And we see this over and over again, that we get a significant increase in HDL, concurrent with the reduction in triglycerides, and you've heard in previous talks, that's a very powerful predictor of reduced atherogenic risk. And then blood glucose, which wasn't super high in these patients anyway, went down somewhat.
Further on this 2008 study of randomized control trial of low fat versus low carb. Further results. The low carb diet group lost more abdominal fat, triglycerides, and glucose. They gained more HDL cholesterol.
Insulin resistance measured by HOMA-IR, we saw a dramatic reduction in insulin resistance in this group. But the most paradoxical findings on the far right outlined in orange, and that's the blood level of saturated fat.
Their HOMA-IR, which is a measure of insulin resistance, went down. Total saturated fat in the blood went down.
Now, we've heard that dietary saturated fat, the evidence now is, and mainstream thinking is, it's not harmful if you eat saturated fat in your diet. But there is strong evidence that says the amount of saturated fat in your blood is a predictor of future diabetes risk, coronary artery disease risk, and mortality. Those on the ketogenic diet had much greater reduction in saturated fat in their blood, but they were eating 3 times as many grams of saturated fat per day. So if you were taught, and if you still believe that you are what you eat, a red X. This is not true. You are what you save from what you eat. We get keto adapted, we more than double our body's ability to burn fat, and one of the preferred fats used in that fat oxidation is saturated fat. So it isn't going to harm you if you take it in, you turn it into CO2 and water. Tremendous benefit to your health if you reduce blood levels of saturated fat. And we've now seen that in 5 separate studies. This is not an isolated observation. And of those 14 biomarkers, 7 of them went down significantly more in the group on the high-fat, low-carb diet than in the control diet. None of them went down more in the group that was on the low-fat, high-carb diet. C-reactive protein here was one of the 7 that did not go down on the ketogenic diet in the first 3 months. It doesn't mean it doesn't go down. It means it doesn't go down in the first 3 months. It's a slow responder. So when you read papers that says that the ketogenic diet followed for a month makes CRP go up, hang with it, dude. For a week, he had them eat from a buffet, choose as much food as they wanted to eat from a buffet of very nice, good foods that were rich in carbohydrates and relatively low in fat. And they monitored what they ate, and they ate about 3,100 calories per day. Now, these are severely overweight individuals, and they held their weight stable, and they measured their blood glucose, which is shown in the top panel here in the black, and their blood insulin levels, shown here. So high glucose, and this is millimolar glucose. Normal glucose is 5.5, the upper limit of normal is 5.5. So this is where normal is, and these people were running glucoses across the day around or above 200 milligrams per deciliter, so about twice normal. They took away all the carbs from the food, but still had very good, delicious foods out there, and they could eat from the buffet, and had them eat as much as they wanted to, and they spontaneously reduced their calorie intake by 1,000 calories a day, which is exactly what Jeff had seen when we predicted in that 2008 study that we published. So they reduced their calorie intake by 1,000 calories a day, and yet they reported better satiety. And in 2 weeks, when they went back and did their blood glucoses, and these are blood glucoses done every 2 hours across 24 hours, and looked at their insulin levels, they had a dramatic reduction. And remember, 5.5 is the upper limit of normal. So upper limit of normal is here. These are their glucoses after just 2 weeks of the ketogenic diet. And you can see that they're in range, in the normal range, most of the day after just 2 weeks. But at a markedly lower insulin level, if you'll see in the lower panel in blue. Now, the only way you can reduce your blood glucose and have with lower insulins is you have to improve your insulin sensitivity. And what they demonstrated was there was a 75% reduction in insulin resistance, or a 75% improvement in insulin sensitivity in 2 weeks with very little weight loss, which means this is not what many of the critics say, well, any diet works if you lose weight. You don't need to lose weight on this diet to get most of the benefits. And again, this is very early in the adaptation process, and things get better with time. Again, a metabolic ward study, they took away more than half of their medicines in the first 2 weeks, When you initiate this diet in somebody with diabetes or severe hypertension, it's metabolic rock and roll. Things change quickly. So this is how Verta got started. And the key technology here is you can do this safely in outpatients if you have constant communication and expert physicians and coaches managing that patient. Basically, this is a patient-centric program and a patient-centric app. You know, this is not an app that's designed for billing, and yeah, we need to start learning how to do that, but it's really designed with having the coach in the upper right-hand corner and the doctor in the lower right-hand corner interacting with the patient monitoring data and logging it in through the app and getting access to their data through the app so they see all their data. And the other thing is putting the patient in contact with a peer support group, which augments the coaching process to allow them the comfort and security to know that they're doing the right thing and that other people are dealing with the same problems and communicate among themselves in terms of peer teaching. And these were people with type 2 diabetes. The average duration of their diabetes, which is important, was 8.4 years. It's much easier to reverse or treat or improve diabetes in people early on in their diagnosis, but when they've been at this for an average of 8 years, you know, there's a lot that's been going on in the pancreas. These are tough patients to deal with. They were very obese. They had a BMI of 41. And the diet that we used with these patients was basically what we did with the metabolic syndrome study that I showed you that Jeff Volek and his team did. 1.5 grams of protein per kilogram reference body weight. Again, based on the observations of Stefansson when he was locked up in Bellevue Hospital. Because they were very insulin resistant and type 2 diabetes, we gave them only 30 grams of total carbs per day. And here's the important thing. We had them eat fat to satiety. This is not a calorie-restricted program. We did not count calories. We did not tell them to restrict calories. We told them not to be hungry. Eat to satiety. So we had in-person group training and management and in-person physician monitoring and so on, and the other half got this incipient app that we were developing, and I was sure the app wasn't going to work. We didn't see any difference in the first year between the two. Proved myself wrong. I like doing that because that's how I learn. We've published, these are 6 papers that we had published as of 2 years ago. We have another 3 papers published. If you read any one paper, read our 2-year data from Frontiers of Endocrinology, which shows that the 2-year data from our randomized clinical trial. I'll show you some of these data here. This answers the first question. Can people really stick with this kind of program? We had 83% retention at 1 year and 74% retention at 2 years. So excellent retention. And in the lower right-hand side of this diagram, you can see blood ketones that were being measured every day, reported through the app. And you can see that, again, this is a very insulin-resistant population, and yet the group mean ketone increase was up to 0.8, and they maintained that for the first 3 or 4 months, and they stayed at or above 0.5 out to 8 months. And even at the end of a year, they were about 0.4. So people can follow this diet, they can stay in nutritional ketosis if you give them the right information and adequate support to help them do that. It's tremendous benefit to adherence when people come off of their drugs and their weight goes down and they're looking at blood sugars that are better than anything they've seen in 8 years. That's remarkable. What happened to hemoglobin A1C? The blue bar at the bottom is our intervention, the 2 intervention groups together. The black line at top is the group of patients who were in the usual care. And you know, it's a standard understanding that type 2 diabetes is a chronic progressive disease, and these people, hemoglobin A1C was slowly going up even in the course of 2 years. And it depends on whether you talk about remission. We like to talk about reversal, because remission sounds like you got to a destination, and I like the term reversal because it means you're going back in the right direction towards metabolic health. By reversal means we take them off all their diabetic medicines except metformin. And we had 55% of people at the end of 1 year who had reversed their diabetes by those criteria. This shows medication use. It's kind of complex, but on the far left-hand side is our sulfonylureas and insulin. The sulfonylureas we completely withdrew because they're very dangerous drugs, inducing hypoglycemia. 54% of the patients stopped their insulin. Almost 40% reduced their insulin drugs in the middle were drugs that we didn't regard as dangerous and weren't as active in reducing them. And on the far right-hand side, you see metformin. If the people were on metformin and had no side effects from it, we did not stop it. But I think there are ethical issues of stopping a drug that isn't having side effects, that's very cheap, and which has known benefits of preventing progression to diabetes. Because this cohort of people are at very high risk of progressing to type 2 diabetes. So we don't stop it. This is a Eat to Satiety study. It was not a calorie-restricted diet. We weren't focusing on weight loss. But this shows you the weight change for the two cohorts across 2 years. And you can guess that the blue patients are the ones who were on the Virta program. And we had progressive weight loss down to 1 year. We did not see, as a cohort, the group begin to start regaining some weight till about 14 months. So there is some weight regain that we saw in the second year, but it was very modest compared to what one sees in a lifestyle program. But we saw a 12% reduction in 10-year atherosclerosis risk based on a standard predictive equation. One thing that, the blue bars are, anything going up is improvement, reduced risk, anything going down is increased risk. The only blue bar going down, which is our intervention group, was LDL cholesterol. If you look over here on this side, this is the small, dense LDL, the atherogenic LDL. It improved, even though LDL slightly increased. The other thing I'll point out is, with the purple bar over there, that's C-reactive protein. At 3 months, it doesn't go down. And in this study, I won't show you, CRP did not go down in the first 70 days of the study. But at 1 year, we saw a dramatic improvement in CRP, and also an improvement in white blood cell count right next to it, which are both recognized predictors of diabetes risk and heart attack risk. But these are 16 biomarkers of inflammation that we measured at 1 year and 2 years in this population. Here we've got 14 out of 16 going down. And if you're into statistics and you want to say, well, how powerful is that? All 14 of those 16 that we say went down significantly, the p-value was 0.001 or less. And so what we're looking at here is a broad spectrum anti-inflammatory intervention. If you take an anti-inflammatory drug like the modern statins reduce CRP. They'll reduce it about 25%, but it has no effect on other biomarkers of inflammation. It's a single focused drug. This is a much broader perspective. When I used to think that the value of ketones was it takes fat and process it in the liver and you make fuel for the brain, that was the 1960s thinking. And then what we now know is it's an excellent fuel for the heart. And also, very interestingly, beta-hydroxybutyrate is an extremely effective fuel for the gut. Beta-hydroxybutyrate is a 4-carbon fatty acid with 1 extra oxygen added to it, beta-hydroxybutyrate. A good microbiome, given a good source of fiber, makes something called butyrate. 4 carbons, no extra oxygen. They differ by 1 molecule. Both of them are superb fuels for gut mucosa. They both have anti-inflammatory effects in the gut, although the anti-inflammatory effects of beta-hydroxybutyrate are probably better. So if you're worried about gut health on a pure carnivore diet, if you got ketones of 1.0, don't worry. This looks at the problem of weight rebound in multiple studies. The green line here that goes up to there, that's called the DIRECT study. That was published in The Lancet a couple of years ago. And this is a formula, roughly 850 calorie formula diet to treat people with early stage diabetes. This drop here is 3 to 5 months of drinking a liquid formula. And then when they go back on a healthy diet, their weight starts going up. The purple here is a very low calorie. This study was actually published in the 1990s. They used OptiFast at 500 calories a day for 3 months. Then they took them off the OptiFast and told them to eat a low-calorie diet for a few months. Then they put them back on OptiFast, but you can see great response initially, but the second time they had them drink this 500-calorie-a-day formula, it didn't work. And it probably didn't work because once they've been on it and went off it, when they go back on it, the body is, the signals to the brain are so intense to eat that they couldn't adhere. I really credit Dr. Rena Wing and her team because they published these data. This is weight went down, But when they went back on the low-calorie diet after the second try of the very low-calorie diet, by the end of a year, they're going back up, and much of their weight was regained by 2 years. So this is a dramatic change in their weight, both down and back up. And this is a classic response. The blue here in the middle is Virta, and we go down, we stay down at 1 year, and then there, as I showed you, a slight weight regain. This shows hemoglobin A1C changes. Again, you get a much bigger drop when you're on an extreme diet, but then it goes right back up when you no longer follow the diet. If you have something that can be sustained long-term, you have a much greater likelihood of achieving lasting benefit. These studies include patients with diabetes with gastric bypass or gastric sleeve surgery, plus the Look Ahead study, which was a very intensive lifestyle intervention. And you can see that it's a common observation that everything goes down when you have a very effective treatment, but for most of them, it's going back up. Oh, by the way, this one that's completely flat here, this was the control group for the Look Ahead study where they did no intervention, and no change in their diabetes, and luckily no upward trend. You get a lower slope and better lasting results when you deal with something which is sustainable and planned to be followed long term, and that's what we do with the well-formulated ketogenic diet. The biggest problems that we deal with that are easily manageable is getting people to eat enough sodium and eat enough potassium. Because if you don't, there's problems. So for sodium, if you don't eat enough sodium when you're on a ketogenic diet, because you have this natriuresis of fasting, the kidneys accelerating their loss of sodium, you will become sodium depleted, and that will lead to increased cortisol and cortisol stress.
If you become sodium depleted, it leads to increased cortisol and cortisol stress.
And if it goes on a long time and you just feel crappy all the time, they'll say, well, you've got adrenal fatigue. There is no medical diagnosis of adrenal fatigue. That's sodium inadequacy.
There is no adrenal fatigue. It is sodium inadequacy.
And you don't wait till it happens and say, oh, we'll give them a gram of sodium or 2 grams today. You treat them with the sodium from day one. When we send a starter kit to the patient, we send it with their choice of vegetarian or chicken bouillon. Actually, one of each, because they taste it and find out what they want to buy. We have to give them the stuff to start with to get them to take it and understand that it's necessary. Is that safe? Well, there's an amazing study published in the New England Journal of Medicine in 2014 by a group at McMaster University in Ontario, Canada. But the study was from 100,000, from 17 countries, where they did something really innovative in terms of studying sodium requirements. What this shows is the mortality curve for they measured sodium excretion as a surrogate for sodium intake, and this is the 2.3 grams that we're all told we should be eating. And you can see that the mortality risk here is 1.5 times the lowest point, which is at between 4 and 5 grams of sodium per day. So for healthy populations across 7 different countries is between 4 and 5 grams of sodium per day. And if you eat more than that, you can see the curve as it goes out to the right doesn't go up very fast, but it goes up really fast if you severely restrict sodium. So sodium is absolutely necessary.
The lowest risk of death, sodium intake, is between 4 and 5 grams or more. Less than this raises the risk abruptly. More than this raises the risk very slowly.
We see the same kind of things with potassium. And I titled this slide, The Role of Vegetables in Broth. And the reason is that if you're a pure carnivore and you eat 1.5 grams of protein per kilo, which is about 15% of energy intake, you're going to be at about 1 gram of potassium intake per day. If you eat 3 grams per kilo or 30%, you'll be over here. So this idea that you have to eat 30% of your protein will actually give you enough potassium to be reasonably safe. But if you're eating 1.5 grams per kilo, you have to get your potassium from somewhere else. And if you then add homemade broth to this, you can get out to a place where it's very safe.
Virta Health recommends 3 to 4 grams of potassium per day. If you're eating 1.5 grams of animal protein per 1 kilogram of ideal body weight, that is only 1 gram potassium. If you're eating 3 grams of animal protein per 1 kilogram ideal weight, you're in much better shape. Need more potassium? try non-starchy vegetables or homemade broth, or you can try desiccated animal organs, blood, bone, etc.